Thank you again for the invitation to speak today. And apologies that I could not be there in person, for what I'm sure is going to be an excellent meeting in Lucknow. And so I have no financial disclosures to disclose, but what I would like to talk about in the next 35 to 40 minutes, and unfortunately I can't cover everything when it comes to ampullary and periampullary neoplasms, and admittingly these neoplasms arising from this location are very rare. And therefore, I'd like to take a more detailed approach to this talk with a focus on ampullary and periampullary adenocarcinomas, and to walk you through the steps that I take, honestly, every week, specifically an integrative approach to evaluating these neoplasms by combining careful gross inspection with microscopic findings. And along the way, discussing critical aspects that can impact patient care, such as subtyping and ancillary studies like mismatch repair, HER2 assessment, along with a few words as to where I see us heading in the future when it comes to these neoplasms, which of course is molecular testing. Before that, let's start off with a case. And honestly, there's really no better way to present a systematic approach to these neoplasms without going through that step-by-step thought process that we all take when evaluating these lesions. And therefore, it's important probably to go through this process to kind of show you how I approach these types of neoplasms. And so without further ado, really a number of years ago, a 52-year-old male presented to a UPMC cardiologist complaining of heartburn, nausea, and occasional vomiting. The patient was obese and had been started on a GLP-1 agonist, which is really gaining a lot of fame here in the United States, and specifically that of Ozempic. And although he was losing weight, the side effects of Ozempic were getting worse, which caused the cardiologist to start questioning whether this was really due to Ozempic or something else underlying in this patient. And so he drew up serum studies, which were remarkable for an elevated liver transaminases as well as elevated total bilirubin. Considering the patient's symptoms may be unrelated to Ozempic, the cardiologist referred the patient to a gastroenterologist who not surprisingly performed an EGD or esophageal gastroduodenoscopy, as pictured here, which found an apple core type lesion that circumferentially wrapped around the ampullary region of the duodenum and was bile stained, consistent with likely an obstructive process. Unfortunately, biopsies of the rim of the lesion were necrotic, and due to clinical suspicion of a malignant neoplasm, the patient underwent a robotic-assisted pancreatic duodenectomy, which upon really bisection of the specimen along the pancreatic and common bile ducts, a technique that I'll go into vast detail in my talk later, a superficial mass was identified in the ampullary and periampullary region, as noted by the white arrows and dotted line. Microscopically, the mass emanated from the ampulla with a well-circumscribed border that extended into, but not through, the musculature propria of the duodenum. And histologically was consistent with a glandular neoplasm, with a perilymphoid cuff at the leading edge, and in other areas, a syncytial growth pattern that is characterized by tumor cells arranged in broad, confluent sheets, where the cell borders were indistinct, and the tumor cells are closely packed with minimal intervening stroma, except for really prominent lymphocytes that was, again, peritumoral as well as intratumoral in distribution. Now, before going any further, it's important to form really a differential diagnosis of mass-like lesions that can arise from the ampulla and periampullary region, which can be broadly classified into non-neoplastic lesions, benign neoplasms, and then malignant neoplasms. Now, of course, many of our benign neoplasms can transform into malignancy, and we'll get a little into that a little later. But overall, three categories of which non-neoplastic lesions often include lipomas, inflammatory type polyps, and lymphangiomas, typically those associated with chronic irritation of the ampulla. Among benign neoplasms, of course, those include your adenomas, typically your tubular adenoma or tubulovillous adenomas, very akin to that of what we see in the colon or just regularly the luminal GI tract of the small intestines, that are actually increasing in incidence. But it's also important to remember that you also have your pyloric gland adenomas of the ampulla, as well as serrated adenomas, which are also increasingly being recognized. And it can occur actually in this location, and actually the serrated adenomas can often be missed. But don't forget about your neuroendocrine tumors, and probably the coolest lesion of them all are your gangliocytic paragangliomas, or their new name, COGNET, composite gangliocytoma neuroma, and neuroendocrine tumor. And finally, you have your malignant neoplasms, such as adenocarcinoma, neuroendocrine carcinomas, and although a precursor neoplasm, intraampullary papillary neoplasm, or IAPN. These neoplasms are almost always seen in association with an associated, invasive adenocarcinoma, and you just have to really look carefully. Sometimes if you really look carefully, look at that IAPN, you will find an invasive component next to it. But as I mentioned at the beginning of my talk, I can't do all of these entities really justice in the time that I have. So it's probably best to truly focus on one entity well, and probably the most relevant are the adenocarcinomas that arise from this location, and really important from a pathology perspective to just honestly just simply get it right. And like any adenocarcinoma, by definition, these neoplasms are malignant gland forming that have an epicenter in or around the ampulla. Thankfully, these neoplasms are rare, but they are associated with a poor prognosis, typically on the order of a 15 to 20% 5-year survival rate. Patients often present with jaundice, abdominal pain, pancreatitis, and sometimes weight loss before coming to presentation. And these are typically due to secondary obstruction by a resulting mass lesion at an area that's unfortunately inopportune, being right next to the pancreatic duct and common bile duct. Patients are often older adults, but we are starting to see these neoplasms pick up in incidence and may be associated with a genetic predisposition, such as patients with familial adenomatous polyposis or even attenuated FAP, along with Lynch syndrome, which is associated with mismatch repair protein deficiency. Before going into detail regarding these neoplasms, it's important to have really a solid foundation of the anatomic and histologic really features and landmarks of the ampulla itself, as I find these are one of the biggest pitfalls for a practicing pathologist to really go down the wrong road. And let's start really with what is the ampulla, which really is a complex anatomic region that represents a true junction of the duodenal, pancreatic, and biliary type mucosa. While multiple types of carcinomas arising from the duodenum, bile duct, and/or pancreas often extend into the ampulla, an ampullary adenocarcinoma must truly be centered on or circumferentially surround the ampulla to be regarded as an ampullary primary. And that honestly requires proper gross technique and examination to assess the tumor epicenter. And that all starts at the time of honestly receiving the specimen, which really honestly comes right actually at the point of time where it leaves the surgical field and the margins of resection are being evaluated by, again, that pathologist. The first step is to identify the uncinate process of the pancreas, really a landmark or a hook around the superior mesenteric vein and artery, and creates an indentation or notch on the pancreas called the vascular groove. Again, that uncinate process and vascular groove are extremely important in providing landmarks that we'll be dealing with in how to orient the Whipple specimen, and actually how to open it up along the ductal system to make sure we're actually identifying the appropriate ducts altogether. Now remember, the Whipple specimen itself comprises the head of the pancreas, a C-shaped loop of the bowel, and a portion of the bile duct. The gallbladder may or may not be attached to the specimen once received. When orienting the specimen, many pathologists liken it really to a right hand, with the thumb as the uncinate, fingers as the pancreatic knuck, and the recess between the thumb and index finger as the vascular groove. I use actually that vascular groove as a guide to identify my margins of resection. Present here is a picture of the pancreatic head from a Whipple specimen with the stomach to the left, the duodenum to the right, but obviously you're looking face at the the pancreatic specimen itself with an identifiable smooth surface, which is your vascular groove. The vascular groove is often a trapezoid in shape, where the superior mesenteric vein and artery often rest upon it. And so it's easily released typically when there's lack of involvement of those structures, but honestly just get dissected away by the surgeon, creating that nice smooth surface as opposed to the cauterized periphery around it. To the left of the trapezoid vascular groove is the pancreatic parenchymal margin that should have an eccentrically placed opening that corresponds to the pancreatic duct. The blue probe is within the pancreatic duct. And at the top of the trapezoid, again, that vascular groove is another opening that corresponds to the common bile duct, as shown here, and held open by the gold probe. Now, it's very easy to accidentally miss that bile duct and actually probe into a vascular structure. And therefore, putting that probe through the bile duct and then hitting the ampulla is imperative in making sure you are actually in that common bile duct. I've seen many people take an unfortunate pitfall in serially removing a vessel rather than the common bile duct margin. Lastly, to the right of the trapezoid vascular groove is a friable area that corresponds to the uncinate resection margin, which we won't take for frozen section, but important again as we assess margins in the permanent specimen. Now, understanding and visualizing these landmarks will make identifying the corresponding resection margins, especially the frozen section, much easier. Upon identifying the appropriate landmarks, the next step is to shave the pancreatic neck and bile duct margins. I first ask our staff to completely shave the pancreatic neck margin with at least 2 to 3 millimeters in thickness. There's often significant cautery at this margin and may require going somewhat deeper into tissue to get a good representation of the margin, but also important to make sure that tissue sticks onto that frozen section slide. Moreover, based on the new AJC 8th edition for pancreatic exocrine neoplasms only, cancer within a millimeter of a margin is considered to be a positive margin. Now, obviously, this is not relevant for ampullary-based lesions, but you never know what you're going to be dealing with until that specimen is opened, so why not be particularly important and sensitive to this area? Similarly, with the bile duct margin, we try to take the entire ring to include the surrounding soft tissue. In many instances, the gallbladder may not be attached to the specimen, and if not, 2 lumens may be present. One is the cystic duct, and the other is the true bile duct margin. Unfortunately, due to the difficulty in distinguishing between the two, when the gallbladder is not present, we actually take both the bile ducts as the bile duct margin for frozen section. So honestly, it's pretty easy for our surgeon to take another section of the bile duct going higher, closer to the liver hilum, if any of those margins and those rings are positive when it comes to the bile duct. So I don't really lose much sleep over that. Lastly, there are 2 types of Whipple specimens that may be received. First, there's the classic pancreatic duodenectomy that includes not only the duodenum, but the attached gastric pylorus. The second is a pylorus-preserving pancreatic duodenectomy, as pictured here. In cases of pylorus-preserving pancreatic duodenectomy, we will also take that proximal duodenal resection margin. It's not too infrequent that a cancer involving the ampulla extends laterally, microscopically, to the proximal duodenal resection margin. Therefore, a positive proximal duodenal margin will alert the surgeon to remove the pylorus to ensure he or she has gotten around that cancer within this region. So very important to understand what type of specimen you are receiving and where are those margins overall. Now, while these margins are being frozen and sectioned, for which we evaluate 3 good sections for each margin that represent, again, at least 1 millimeter in thickness, another member of our staff will open up the specimen, typically the pathologist, first along the bowel contralateral to the head of the pancreas to identify any masses or lesions within the bowel and obviously the ampulla itself. And then to enter 2 probes into both the main pancreatic duct and the bile duct. Once those ducts have been probed, the specimen is opened along the ducts with a long blade using a probes as a guide. Sometimes I might even stick 2 probes into each duct and put that blade right between each set of probes that are paired together, making sure that I stay within those ducts themselves and never skive left or right or away from the ductal system altogether. Slicing the specimen straight into a half, into that literally you have a bisected specimen, opening the specimen, giving that pathologist the time or really the idea of where that mass lesion is with respect to all the anatomic landmarks while all the frozen sections are being done. In other words, are we dealing with the neoplasm arising from the pancreas, bile duct, ampulla, or small intestines, and its proximity to the respect to the margins that have been taken for frozen section? It certainly lets me sleep a little better at night calling a margin negative if I know that the tumor is grossly far away from those margins. But importantly, this technique helps identify the epicenter of the neoplasm. And for the purposes of this talk, specifically, truly, is it the neoplasm arising from the ampulla, or is it actually extending into the ampulla secondarily, again, from the pancreas, bile duct, or rather the small intestine? Now, when open, the pancreatic duct and common bile duct should be clearly identifiable, and both ducts should merge at the level of the ampulla. If they don't, this is known as actually pancreatic divisum. That should be documented within the subsequent gross report. The case shown here is really a normal specimen for reference. But when it comes to ampular neoplasms, actually many of them are exophytic, and it actually can be noted to be bulging from the ampullary orifice before even bisecting the specimens, actually at the time when you just open up the luminal GI tract, that being the duodenum and stomach if attached. However, I've seen many biliary and even pancreatic primaries present with a bulging major papilla. And so that's where it's still imperative to cut along the ducts, very sensitive to this position here. Hence why it's really important to really understand the anatomy of which that neoplasm is truly arising and where that epicenter is. Certainly, again, you can have a pancreatic cancer really presenting similarly, really undermining the ampulla and growing into the ampulla itself. But in this case, you can see that that exophytic lesion truly is emanating from the ampulla with dilatation or subsequent dilatation of the common bile duct and pancreatic duct due to obstruction. However, not all ampullary adenocarcinomas are exophytic. Some are endophytic or rather ulcerated, and without proper grossing, it can be downright challenging to distinguish this case from a biliary or a pancreatic primary growing into and involving the ampulla itself. As further proof of cutting the ducts, really cutting along the ducts, a small intraampullary neoplasm can be easily missed without proper grossing skills. And again, I really harp on the fact that just probing those ductal systems, cutting the specimen, bivalving it completely all the way through the ampulla, not leaving it like a book to be opened at the hinges, but rather cutting through the specimen itself can really reveal a lot about what's going on with that neoplasm and where it's truly arising from. Can't be said for how important grossing technique is when it comes to these small sub-centimeter neoplasms found to be impinging upon the ducts, consistent again, in this case with the intraampullary adenocarcinoma. Now, as per the College of American Pathologists, and I know I'm talking to audience in Lucknow, but per CAP, ampullary adenocarcinomas can be grossly subdivided based on location as intraampullary, periampullary, or both. And so, again, this grossing technique itself really lends itself to being able to designate where the location of these neoplasms are, if they're intraampullary or periampullary, or do they encompass both areas altogether. Here's one last example of a subtle intraampullary adenocarcinoma where we slightly miss the epicenter, but it is wrapped around the ampulla and undermining the pancreatic ductal system, and in fact, growing underneath that ductal system overall. Now, not every ampullary adenocarcinoma is going to arise from the major papilla, and instead, this ampullary adenocarcinoma is actually centered around the minor papilla and growing laterally into the duodenum. But you really can't get that geography without, again, cutting along the ductal system, probing the system itself, and really examining this at the time of actually opening the specimen fresh, as opposed to fixing the specimen or inking the specimen and then losing all those important landmarks. And again, really proper grossing examination, obviously combined with microscopic examination, which I'll talk about in a second, are extremely important. But what is the actual extent of the ampulla? And I think that I get that a lot when I talk about the ampulla in the periampullary region, is that what is the definition of the ampulla itself? And honestly, and really it is arbitrary. It's based on what we've known for decades, maybe even a century. And per most investigators, the ampulla is arbitrarily defined as about 1.5 centimeters long and transverses the duodenal wall, opening into the duodenal lumen through typically the major duodenal papilla or major papilla, known as the papilla of Vater, excuse me. Of course, minor papillary ampullary adenocarcinomas can occur, and although they're actually quite rare, and often actually those minor papillary adenocarcinomas typically occur in the setting of divisum. But that being said, microscopically, the ampulla, that being either the major papilla or minor papilla, are composed of prominent papillary folds with epithelium that transitions from intestinal type, that being the duodenal surface, to foveal-like mucosa with occasional goblet cells in the papilla region, really to eventually transitioning into a pancreatobiliary type epithelium as it goes deeper down into the ductal system. Now, small mucus glands and ductules underlie the mucosa with intervening smooth muscle, which is known as the sphincter of Oddi. Now, I hate really examining the ampulla at high magnification because it looks so busy when I look at it, especially on biopsies. But even surgical resection material looking at the ampulla, when you look at it at high power, those subepithelial ductules maintain really a very disorganized lobular appearance that can be easily confused or misconstrued as an infiltrating adenocarcinoma. And I can't tell you how many times I've seen a consult where a patient had maybe a pancreatic ductal adenocarcinoma and a pathologist took another section of the ampulla, which they should, and they're concerned that was there something pathologic occurring in the ampulla, whether it be dysplasia or even a potentially malignancy. But it's important to understand that reactive processes do occur in the ampulla and can look highly atypical from an architectural perspective. So it's essential to not only evaluate the architecture, but really the cytologic features in parallel when it comes to the ampulla, especially when dealing with biopsies of the ampulla. Which leads us to really the microscopic findings of adenocarcinomas of the ampulla, where it's critical to remember that these neoplasms can arise from multiple lineages, such as, again, the intestinal, pancreatic, biliary, and easily can be found to have mixed histologic patterns. It's also imperative to look for precursor neoplasms, such as adenomas and intraampullary papillary neoplasms. And with multiple lineages, it makes sense that microscopically these adenocarcinomas can be subdivided into typically three types: intestinal, pancreatibiliary, and mixed neoplasms. Intestinal type adenocarcinomas typically arise from the superficial mucosa of the ampulla, which makes a lot of sense, very mimicking that duodenal type or small intestinal type adenocarcinomas, and adopt a columnar appearance with invasion with that are characterized by elongated nuclei, scattered goblet cells, and sometimes even Paneth cells. In this case, one can appreciate the cytoplasmic clearing of the foveolar type epithelium, as pointed out by that white arrow, and then rare goblet cells by the yellow arrow. In comparison, the pancreatibiliary type often arises more intraampullary and often deeper down in the ampulla itself. Again, that's where that lineage, that pancreatibiliary cell type lineage, is present and makes sense, often having really the majority of the neoplasm being intramural in the ampulla itself and characterized by cuboidal but pleomorphic cells. They look uglier, forming smaller glands, complex architecture, sometimes cribriform architecture, in a background with or without desmoplastic stroma. There are many times that a pancreatibiliary type adenocarcinoma has very little stroma itself and can actually mimic a dysplastic lesion when in fact it's really an invasive adenocarcinoma. Now, there also exists that mixed type ampullary adenocarcinoma, which shows a combination of, again, intestinal and pancreatibiliary type epithelium, as the name would imply. However, often the mixed type is really pancreatibiliary type with multifocal areas of really intestinal type areas itself. But subtyping honestly isn't always easy and or straightforward, and therefore many organizations and even the National Comprehensive Cancer Network here in the United States advocates for immunohistochemical subtyping as a potentially improved or rather objective methodology of stratifying these types of adenocarcinomas. Immunohistochemical subtyping is based on a relatively large study done at Memorial Sloan Kettering, probably about now a decade ago, that defined intestinal type adenocarcinoma as positive for the intestinal markers such as CK20, CDX2, or MUC2, but strictly negative for MUC1, typically a pancreatibility marker. Alternatively, if MUC1 is positive, but all three intestinal type markers are positive, then the adenocarcinoma should be classified as intestinal type. In contrast, pancreatibilary type is positive for MUC1, but negative for CDX2 and MUC2, irrespective of CK20 staining. And lastly, all other combinations, including quadruple negative staining, which is extremely rare, are considered to be ambiguous. Now, many authors have argued that this methodology is flawed. However, no one has presented an alternative, and it's been a decade since then. And so I'd have to say that, unfortunately, we don't have anything better. But I would say that there are a significant subset of ampullary adenocarcinomas that I would have thought would be intestinal type by histology, but are classified as pancreatibilary by immunohistochemistry. And that ambiguous group can contain close to 15 to 20% of ampullary adenocarcinomas, depending on how well your immunostains are working in your lab and their specificity. Honestly, antibody clones themselves can show different results. So it's not perfect, and I don't blame Memorial Sloan Kettering nor Emmett Todd, as he wasn't actually even there in 2014. He was still in Brigham. But nevertheless, we have really nothing better. But it does offer some methodology to really benchmark how we eventually evaluate these patients. And then eventually studies will come out that includes other ancillary studies, and hopefully one day subtyping will be improved. But importantly, why subtype? And that's probably the crux of the matter. Well, classic literature states that intestinal type ampullary adenocarcinomas are associated with a better prognosis as compared to pancreatic biliary type adenocarcinomas. Now, one could also argue that the prognosis of both types, especially with lymphovascular invasion and positive lymph nodes, perineural invasion, etc., is bad overall. And in fact, ampullary adenocarcinomas are not a well or improved prognosis compared to other GI neoplasms. But there is something to be said when it comes to treatment, and specifically first-line treatment. For intestinal type adenocarcinoma patients, often these patients will receive a colon-specific regimen, such as FOLFOX or capecitabine with oxaliplatinum. But for pancreatic biliary neoplasms or adenocarcinomas, our oncologists try to be more aggressive with a pancreatic adenocarcinoma regimen or type regimen, such as modified FOLFIRINOX or GEM plus CAPE. Certainly, all patients are treated aggressively. It's an aggressive cancer, but as this disease can affect older patients, often these patients have other comorbidities. And after a major procedure, such as a Whipple procedure, we don't want to be too aggressive with management such that it really impairs their ability to get adjuvant therapy, especially when we don't have to. Now, lastly, it's also important to mention that mixed type adenocarcinomas are often treated similar to pancreatic biliary type adenocarcinomas for the same reasons I mentioned before, that mixed type adenocarcinomas are often predominantly pancreatic biliary and only a minority of intestinal type areas are present. But subtyping an ampullary adenocarcinoma is only really half the battle. The next challenge is staging the cancer, which is not necessarily intuitive and differs from the small intestine and, more importantly, the colon. The ampulla is a very complex structure, as I mentioned, and doesn't have simplified layers that we expect from the rest of the luminal GI tract. And the pathologist that I've at least dealt with often find it troublesome staging these neoplasms appropriately, primarily those neoplasms that straddle gray areas, as actually defined in yellow, between various T stages, such as those between T1A to T3B, can prove to be significantly challenging. But focusing really on, I guess, a systematic approach, it actually gets quite simple. So let's first focus on T1A adenocarcinomas. These neoplasms are actually limited to the ampulla, or more specifically, the sphincter of Oddi, with an absence of invasion past the sphincter of Oddi laterally and have not permeated through into the duodenal submucosa. Perisphincteric and more often duodenal submucosal invasion is really the fine line between a T1A and a T1B ampullary adenocarcinoma. But identifying that interface between the sphincter and the duodenal submucosa can be challenging, as the muscle often separates into thin bundles as it approaches the submucosa. An equally challenging area is defining a T2 ampullary adenocarcinoma that extends into but limited to the duodenum. It's important to note that the duodenal mucosa can often be disorganized, even separately or separated by variable sized globules of pancreatic tissue, but should not be confused, honestly, with pancreatic parenchyma. Remember, the development of the pancreas is a very much a multi-step process where you can have ectopic pancreatic tissue, and it's not honestly surprising where you can have what I guess you could say is ectopic pancreatic parenchyma stuck in the ampullary wall itself, and that even being the duodenum muscularis propria. So it's important not to overstage these patients, and then looking at those splayed layers of duodenal muscularis propria. That is also important in determining if the adenocarcinoma has entered the pancreatic parenchyma, which is one of the features of a T3 neoplasms. Now, T3A adenocarcinomas are defined as those that invade the pancreas, but up to 0.5 centimeters in depth of invasion. The difficulty here is that the pancreas can be atrophic. Hence, it's important to really be clean and clear when you cut those cross sections of the ampulla. Again, really, this can be facilitated by cutting along the pancreatic and bile ducts, as shown here again, where you can get really a nice ampullary cut, but only when you're really cutting through the ductal system. Again, by probing it, nicely opening up the specimen, bivalving it into two sections, and then getting nice cuts of the ampulla to show its proximity and its invasion into the pancreas, biliary system, and whatnot. Finally, it's important to appropriately measure from end of the duodenum down to determine if the adenocarcinoma is a T3A, limited to 0.5 centimeters or less, and includes invasion into the pancreas, or does it go beyond that? Now, a T3B adenocarcinoma would also be defined as a neoplasm that extends into the peripancreatic soft tissue, or maybe even the periduodenal soft tissue and or serosa. So not only going past 0.5 centimeters, or it could be just the peripancreatic soft tissue laterally or periduodenal soft tissue itself. Finally, similar to pancreatic ductal adenocarcinoma, a T4 is categorized when the cancer has directly invaded major arterial vessels, such as the celiac axis, superior mesenteric artery, and or the common hepatic artery. Rarely will you ever carcinoma, as these are often unresectable to most surgeons without significant, really sometimes morbid procedures that have to be done in order to take out these major arterioles and arteries themselves. That includes typically a vascular jump graft or anastomosis. And so I don't expect you to see these very often as far as T4 neoplasms, and when they are there, they're pretty obvious. Now, in addition to the issues that I mentioned with regards to T-staging, additional problems that may be encountered are when staging in the presence of an intraampullary papillary neoplasm, or an IAPN, that almost always has an associated invasive adenocarcinoma. These neoplasms often fill up the small ductules of the ampulla and as a precursor can involute and grow downward into the biliary and pancreatic ductal system, and are characterized by both tubular and papillary growth patterns. The old name for these neoplasms was intraampullary tubulopapillary neoplasm, but that was way too long. And so the authors wanted to cut it down, that being the WHO authors, and we cut it down to intraampullary papillary neoplasms to mimic, again, the nomenclature of IPMNs, like intraductal papillary mucinous neoplasms, or IPMBs, intrapapillary neoplasms of the bile duct, and so hence IAPN. The oddity of these neoplasms is that the invasive component of the adenocarcinoma can often grow, honestly, in the wrong direction, defying gravity. By really that wrong direction, I mean they can actually grow upwards to the surface as opposed to downwards deep in the duodenum. And it's an odd way of staging these neoplasms, but again, you have to stay true to the HACC, where you basically determine the T stage based on the layers of involvement and the depth of invasion overall. These adenocarcinomas, like their other intraductal counterparts, that being IPMBs and IPMNs, can give rise to an invasive adenocarcinoma that has mucinous features, maybe even sometimes even mimicking a colocarcinoma. And there's some thought these neoplasms may be more indolent because of that. However, in my experience, they're just as bad as your conventional intestinal type adenocarcinoma overall. The real problem with these neoplasms is also their ability to grow into the ductal system. They can colonize like the bile duct above or the pancreatic ductal system below in this photomicrograph, where the invasive component is limited to the superficial pancreatic parenchyma on the left, but the precursor neoplasms are literally traveling down both ductal systems, extending downward significantly more than the invasive component. Now, again, staging these neoplasms is strictly based on the invasive component. And if they invade actually from another area of the precursor neoplasm, maybe that's in the pancreatic or ductal or biliary systems, they're still called an ampullary primary and would be staged based on exactly where they're located. So if that's an intraampullary neoplasm that's extending into the bile duct or into the pancreatic duct and doesn't have an invasive component till it hits the pancreas or bile duct, well, it's then staged based on where it's located. So if it's in the pancreas and it's going past 0.5 centimeters, it's theoretically now a T3B, even though it could be very microscopic disease. Finally, with regards to end staging, this is also quite different, and in my opinion, gets right at it back really significant amounts of, honestly, clinical data that subdivide the N category into N0, N1, and N2 with involvement of 1 to 3 regional nodes at N1 and N2 with 4 more lymph nodes. This is interestingly very different from small intestinal and obviously colonic adenocarcinomas. The tipping point for small intestinal is not 4 for N2, it's actually 3. And I think a lot of investigators, or rather pathologists, I should say, accidentally misstage these ampullary adenocarcinomas because they're accidentally using small intestinal systems altogether. And of course, colonic systems are the colonic system itself is very different. And I don't think many people would make that problem or actually fall through that pitfall itself, knowing that it's N1A, N1B, N1C, N2A, and N1, and sorry, N2B itself. Now, I think my time is running out. So why don't we end up by finishing up this case that I started with my talk? And if I can remind you, a 52-year-old male presenting with heartburn, nausea, vomiting, and weight loss despite being on Ozempic, that was found to have a mass that had an epicenter within and around the ampulla, microscopically well circumscribed with a pushing border into, but not through, the duodenal muscularis propria, and consistent with a glandular neoplasm with a paralymphoid cuff at the leading edge, along with the syncytial growth pattern. Based on the data I've given you and other areas of the adenocarcinoma, including immunochemical stains, which I'll get into, the resection specimen was diagnosed as an ampullary adenocarcinoma, 2.3 centimeters in greatest dimension. The adenocarcinoma was weakly positive for CDX2, CK20, and rare positivity for MUC2, but negative for MUC1, therefore classified as intestinal type, and limited to the duodenum, and therefore staged as a T2 neoplasm. Interestingly, perineural lymphatic and venous invasion were absent, and all 23 regional lymph nodes were negative. So overall, T2 and 0. So basically the case stops there. No, not really. Now 3 years have elapsed, and the patient has developed, interestingly enough, an ascending colon cancer. And the patient gave us a little more history, that his mother and brother both also had colon cancer. And so that gets very interesting, based on the case that I presented, where an astute pathologist that's actually signed up both the ampullary adenocarcinoma and then eventually that surgically resected ascending colon cancer noticed something interesting. And we've learned more and more about these types of neoplasms in that tip-off, where you have that pushing growth pattern, the syncytial pattern. I know a lot of people are probably understanding where I'm going to get with this, in that knowing that the patient has a history of colon cancer now and a family history, one questions whether this patient may have Lynch syndrome. And that is associated with loss of the mismatch repair proteins. And in this case, a panel of mismatch repair proteins were done that includes MLH1, PMS2, MSH2, and MSH6, with loss of staining of MLH1 and PMS2, while there was preservation of nuclear staining for MSH2 and MSH6. The patient subsequently underwent MLH1 germline testing and found to have a germline alteration in MLH1. So very interesting overall. The patient did actually have Lynch syndrome, which may not be as surprising as it sounds, because many patients with ampullary adenocarcinomas can present actually as initial event of Lynch syndrome. And in this case, the patient did present initially with Lynch syndrome. Honestly, at our institution, any luminal GI tract adenocarcinoma, and I know this is very aggressive and maybe in some consideration wasteful, but we do mismatch repair analysis, honestly, universally for anybody that has a luminal GI tract cancer. Now, it's done mostly for treatment because many of these cancers are advanced and these patients will often recur, and we know that. But we also do it obviously for another purpose, and that is Lynch syndrome screening. Another antibody that we often use, especially with advanced ampullary adenocarcinomas, because we know that they're associated with poor prognosis, is HER2 testing. And so HER2 testing, honestly, we find it very useful. About 10% of our ampullary adenocarcinomas have an ERBB2 or HER2 3+ positivity. And we do that simply with early FDA-approved HER2 immunostain, in this case, the Roche Ventana product itself on a Ventana autostainer. But there are obviously HER2 2+ cases, and we reflex those for FISH testing, and that being the ERBB2 probe, shown in red, with centromere 7, with the probe 17, a probe covering chromosome 17 in green. So my time is a bit up, so I'd just like to summarize. Ampullary, periampullary, and pancreabilary neoplasms should really carefully be evaluated by combining both a gross and microscopic evaluation. Now, I'm sure many of you have different methods that you've used or even read about to open up a Whipple specimen, but I find that really opening up the specimen along the ductal system, determining where a neoplasm is really the epicenter of, can really help in defining the next steps for that patient and really determining what neoplasm that patient has. Here in the United States, we're having a lot of trials that are based off where that neoplasm is truly arising from. And I find that to be definitive. I find it best to be doing it by really gross inspection first and then microscopic evaluation later. Now, in addition to determining the extent of disease, it's important to subtype an ampullary adenocarcinoma, and I've talked about intestinal, pancreabiliary, and mixed types. I do think that those are evolving in what we'll use as biomarkers for them, and that actually could be molecular alterations going forward, but we're not currently there yet. Staging of ampullary adenocarcinoma is very different from small intestinal colonic adenocarcinomas, and I hope you don't make that pitfall, which I've seen many pathologists do, especially with the N2 category. But understanding that the T staging can be very specific and is very important to get really good sections. And again, I'd like to just harp again on that gross inspection, where it's really important to really bivalve that specimen and get really good ampullary sections overall. And then similar to other types, we now have actionable targets. And it's hard to fathom that 5 years ago, we didn't have these, which not only include mismatch repair and HER2, which I've discussed, but now we're seeing an evolution of BRCA testing, POLB2 testing, KRAS, G12C, and other KRAS inhibitors that are coming down the system. And so I think that in the next couple of years, it's a very exciting area, an exciting area of really trials, research, and actually clinical implementation. And with that, I'd just like to thank again for the invitation to speak today. And really, I'll talk to you all during the Q&A session later today. Thank you.